Hello, can you hear me? Good afternoon, everybody, and thank you for joining this session on patient-reported outcomes, patient-reported experience measures in oncology practice. So, my name is Cinzia Brunelli. I'm a senior researcher at the National Cancer Institute in Milano, and I have also the honor to be chairperson of the Cancer Outcome Research Working Group of OECI. I'm chairing in collaboration with Jean-Benoit.
So, Jean-Benoit Burion, I chair the accreditation board of OECI, and I'm based in Brussels, Institut Jules Bordet Cancer Center.
Thank you very much. So, let me say, before starting with the presentation of our four experts here, a few words about this working group to clarify what is the aim of this working group. Outcome research is the study of end results of healthcare interventions. And we are quite good at measuring traditional indicators of results like survival and recurrence and other clinical indicators. We are a little bit less good at assessing patient perception of the results of healthcare. For this reason, we decided for this working group to focus more in these initial years. This working group was established 2 years ago. To focus more on patient-reported outcome and patient-reported experience measures in order to give the possibility to patients to assess their perception of the quality of the results that we are providing with the intervention to them. So this is the reason why we started working on this, and we separated somehow the two different lines of research, one on patient-reported outcome measures, and some of you may know the OnQual project, which is a quite huge EU-funded project that is led by my institution, the National Cancer Institute in Milano, and in which OECI is also playing a major role because we are involving, and in these days it is starting the data collection in many OECI cancer centers for the validation of this tool. Tomorrow we will give you an update on this. On the other side, in this last year, we started working and organizing a working group on instead patient-reported experience measures. And we will today present you some definition of what it is. We will present you some experiences and some potential barriers in the use of these methods. And last but not least, we will talk also about one of the hot topics of this last person, which is the collaboration with patients in the choice of the appropriate tools and in the designing this kind of assessments. So I will invite Sabina, who is the first speaker of today. Thank you.
Thank you. How we can control the... Oh, okay. So, good afternoon. I'm very glad and very happy to be here. This is my first experience, these oncological days. I'm learning a lot from you, so I hope my presentation will provide you some insights and suggestions on these instruments, the satisfaction and experience measures. In case you have your smartphone with you, I will ask you to participate to my speech during my presentation. So next slide, please. Just a few words about, this one? Okay. A few words about me. I'm Sabina De Rosis. I work into the Sant'Anna School of Pisa. That is a public university working on some aspect like management, and in particular, management and healthcare. We have 20 years this year of experience also in collecting the perception of services, the experience with services of users. So patients, caregivers, also professionals. So this is the reason why I'm here for sharing with you the first of the questions we made ourselves about how people can evaluate the quality of care. This was the question opening the paper of Angela Coulter in 2006, Can Patients Assess the Quality of Care? So I kindly ask you to use this QR code for giving me your feedback about this matter. I give you a few seconds just to provide me your perception. And as you can see, 20 years ago, the main topic of the research about this issue was the ability of patients to evaluate the quality of care. Okay, can you please show the answers? Strange. I see the answers from here, but not from there. Okay, let's come back to the presentation. But I can see that the... Oh, ecco. Oh, thank you. So, I'm sorry. Technologies not are always supportive, but as you can see, more than one half said yes, absolutely. And just 9% more no than yes. So I hope that at the end of this presentation, you will change your mind about this aspect. Can we come back to the slides, please? Okay. So this is another paper of Angela Coulter. It's very interesting. The answer to the ability of patients to provide a feedback to the quality of care depends mainly on the way in which we are asking patients about the quality of care. So the answer of Angela Coulter to this question was, well, we should design in a proper way the questionnaires. We can change the way in which the same item, the experience and the satisfaction is asked to patients. So it's very important to build a questionnaire, in the words of Angela Coulter, that asks about real experiences of medical care. What does it mean? We can ask about rating. Are you satisfied about this presentation? A lot? Enough? Not at all? Or we can ask about, did you learn something new during this presentation? In this case, we are asking about an experience. So this is the first and most important difference between the experience and satisfaction measures. Satisfaction, in addition, provide very positive answers by patients. Experience try to objectify. So we are not asking about a general rating, a general evaluation, but we are asking if something happened, if how often, or the intensity of an event. This kind of question, the experience question, are much more easier to understand and to interpret, both for the patient, because it's easier to understand how many times the nurse come to my bed, and also for the professional, because it provides real, concrete data for evaluating experiential aspect of the care. So this is an example of a satisfaction question. It's called rating question. And as you can see, it asks about rating something, in this case, the doctor and nurses collaboration. As you can see, there is a scale that can be based on an evaluation, so from excellent to very poor, or a scale from 1 to 5, or we can have 5 stars, like in TripAdvisor. This is a satisfaction measure. The second one is an example of a patient experience measure. As you can see, it's a reporting question, because we ask patients to report about a real event. Did doctors talk in front of you as if you weren't there? always, often, sometimes, and so on. In this case, we have a scale of frequency of many times, but we can also have a scale of intensity. Usually, for example, some PROMs, the patient-reported outcome measures, are built with intensity scales, for example, about the pain. And this is why we talk about patient-reported experience measures, while patient satisfaction is not reported. These are some examples of what we can measure using patient-reported experience measures. Care pathway. This morning, we talked about the importance of looking at the pathway of the journey of patients, the clearness of information, the process of sharing decision-making, involvement of caregivers. So we can also have CREMS, caregiver-reported experience measures, for example. Emotional support, coordination or collaboration between nurses, doctors, or among them. Comfort of the facility, pain management that is different from the pain measurement. Continuity of care, role of the general practitioner, and so on. For example, this is a nice review of the definition of the patient-centeredness. As you can see in the activities, we found several aspects that we can measure with PREMS. Patient information, the provision of tailored information while taking into account patient information needs and preferences. We can ask patient how much clear or comprehensive or accurate were the information about self-care, for example, or the treatments. Patient involvement care, we can ask about how much the patient was involved into the decision-making. The involvement of family friends, the patient empowerment, the patient physical support, the emotional support. So using PREMS, we can measure also how much the facility is organized around the patient. We can measure the patient-centeredness of our care. This is another paper about the, let's say, complementarity between these two frameworks, the patient-centeredness and the value-based healthcare. And we can find additional aspects that we can measure using PREMS. For example, safety, timely care, asking patients about waiting times, for example, or other events, other behaviors that can be reported by patients that are about these aspects. So, give me a second. I ask you, given these premises, if you had experiences with this kind of patient survey, you should find the second question. I ask you this because during other presentations, some professionals said to me, oh, I discovered that I did, for example, a patient experience survey, while I was so sure it was a patient satisfaction survey. So I have 25 answers. Okay, can we share? Hoping it works. Okay, this time it's working. So it's very interesting. 27% of you did contemporary, maybe in an integrated way, a PREMS, prompts and satisfaction survey. And this is a quite, let's say, relevant answer for me. Some of you satisfaction surveys, then PREMS and prompts had other combination. Okay, can we come back to the presentation, please? This kind of measures, since we are talking about how and why, this kind of mission can be taken in different ways. So I can have an experience with a service and then receiving the invitation for evaluating the punctual, the single experience with the service, like hospitalization survey, for example. But we can also manage to integrate PREMS with longitudinal prompts, or also to provide a longitudinal survey only about the experience with care. Why? Because sometimes we can try to investigate if different kind of experiences with service can produce different kind of outcomes. So, for example, in the experience of my laboratory, we found that different kind of experiential items, for example, the quality of information perceived by patient, had a very relevant and significant impact on the outcomes about, for example, self-care, or adherence to therapy, and so on. Or timely access to some services in the early phase of the pathway had a different impact on the outcome over time. So having also measures of experience can allow us to understand how much the way in which we are providing the service can change the outcome for the patient. And this is, let's say, an exemplification of what Cinzia said before. So we are very used to manage this kind of indicators, rehospitalization, reintervention, mortality. We can integrate this kind of measures along the pathway, so also at the early stage of the pathway with measure of experiences and measure of outcome, for example, left gain along the pathway. So this kind of measures can be used for, let's say, mapping the perception of patient about experience and outcome. So given these insights, last question, I promise. In your opinion, should we stop conducting patient satisfaction survey and focus only on patient-reported measures? Okay. So the most of you said no. And I'm very happy about this answer. Can we come back to the presentation? Thank you. Thank you for the support. Yes, because the real answer to that question is it depends. It depends on the use, why we are choosing patient experience measure, or patient satisfaction, or patient outcome. Because of the impact that we want to create using that data. So coming back to this paper of Angela Coulter, she said that PREMS, so patient-reported experience, can provide a clear view of what you need to improve. So PREMS are very useful for improvement actions. Of course, also for other kind of use, for example, accreditation or performance measurement. But improvement action should be based also on the point of view of patients. In 1988, Avedis Donabedian, who defined this very simple but very useful framework, put satisfaction among the outcomes. This is the reason why we should continue also measuring patient satisfaction, because the satisfaction of patient is per se a quality measure. And there are some studies demonstrating that it can affect also the final outcomes, health outcomes for patients. But PREMS and PROMS can integrate this kind of measure by providing information on the process, in particular, of course, patient-reported experience measures, as I said before, and also on outcome. PROMS, because PROMS are about outcomes, and PREMS, because they can measure the patient-centeredness. The patient-centeredness is one of the results that the system, the healthcare system, the healthcare organization, and the healthcare professional want to reach. So they can be integrated into the same survey, into the same system of measurement for providing a comprehensive information and measuring the value. In this paper that reviewed the different trends in the performance management, patient voice was, let's say, introduced in 2005, around 2005, while currently we talk more about social value. Yes, but this is more theoretically than practically evidence. So we should, let's say, measure value also around the patient voice. So the why about using satisfaction or experience measure depends on the use. So after this, the first paper I used in the presentation, there were other very important papers underlining that these measures are really useful, of course, only if used. And the use of this data we will see in the next presentation is is scarce currently. Using this data, so collecting the right data for the right use is very important also because patients, people participate to survey because they are used. So this is a survey we did in Italy, and we collected the preferences of people to participate into surveys. At the end, they said that they would like to be sure that the results are used by healthcare organizations. So we have to use this data and also to demonstrate that we use them. The dissemination of this data is very, very important because disseminating this data, we can really improve the experience of people. So in this paper, we demonstrated that disseminating data, for example, during training activities or with other kind of dissemination activities, professionals improve their communication with patients. This is the project I'm coordinating in this moment. So if you are curious about how we applied in practice this methodology, you can see this paper or going to the website of my university. And I will leave you my email in case you want to contact me. And also thank you for actively participating to this presentation.
Thank you very much, Sabine. Are there any question or very quick question that we can have there? Thank you.
Thank you so much. Hello, I'm Eliza from Poland. I would like to ask you if you have, maybe you have a clever, sophisticated way how to encourage patients to take part in those proms, etc., and all the satisfaction service.
Thank you for your question. It's a very important question. I can share the experience of a researcher working with professionals, and the most sophisticated way for promoting the participation of people is to convince professionals. If professionals are really convinced and they believe these data are useful, patient will participate because professional will talk about just 1 minute or 30 seconds about these surveys, and this is the most powerful level of participation of patients, for sure. Then we used also other methodologies, for example, sending patients updates about the use of this data. This is very important also. But when they are, let's say, supported, encouraged by professionals, they will participate much more. Of course, each kind of data can be used in different ways. So, for example, prompts can be used also at individual level for clinical care. In that case, the patient is aware of the fact that these data are really used in practice. So this is also a very important lever for participating to continue participating into surveys.
Francesco Lorenzo is from Italian Federation of Cancer Patient Organization. Perhaps I lost it, but I would like to know what kind of patient were answering to this request, and were they still in hospital? They were just what kind of stage of rare disease? Because that would be very important to understand, because it depends also from the age, it depends from the capacity they have to answer, so it's quite a difficult situation. Then it would be very important to know this part. Perhaps I lost it, but hopefully you will tell me again if I lost.
Thank you very much for your question. This is a very critical aspect. Each kind of patient should be engaged with the right methodology. So for example, surveys, currently we often perform online digital survey because it's easier to perform this kind of surveys, are more accessible for younger patients, of course, or for elderly people with caregivers. But, and for example, in our surveys, we have a very important part of the elderly population thanks to caregivers. But what about patients without a caregiver, alone patients or isolated patients? So in that case, our experience is to use different kind of methodologies. For example, qualitative methodologies, interviews, focus group, or other kind of instruments that can help this kind of people to participate. And also the place where they are engaged is very important, because this kind of measure should be collected when people are outside the, let's say, care environment, and not with a healthcare professional, because this can influence, of course, their perception and their answers, but also the caregiver can affect their answers. So, for example, in our surveys, we always ask if there is a caregiver supporting the patient, because in that case, the perception will be let's say, more negative. So all these aspects should be managed, designed before. And what I suggest, and we will discuss this in another presentation, is to co-design the methodology directly with patients in order to understand what is the preferred or most useful way for catching their point of view.
Okay, thank you very much. If there are no other, okay, because we are a bit dead. The last one, thank you.
Thank you. It's a short question, but it requires perhaps a long answer. In a fee-for-service healthcare system, so not a value-based healthcare system, is there room for PREMS? Like, what's the point for assessing PREMS when we are just focusing on diagnosis? Diagnosis is an incentive for the hospital. How can we proceed integrating PREMS in a fee-for-service healthcare system?
I don't know if I really understood the question, sorry.
How can we produce incentive for the hospitals to want to use PREMS?
Yes, this kind of question necessitates a very long answer, because sometimes also in value-based healthcare system, it's difficult to provide the right incentives to the use of these measures. Of course, PROMs have another kind of incentives, because clinicians, professionals can use that measures in the clinical practice. But in the case of PREMS, it can be managed with different kind of levers. There are managerial levers, for example, some system put incentives linked to the budget or linked to the additional payment to managers and to professionals, or they can put goals to be reached in a mandatorial way. But there are some soft levers that can be much more useful. For example, the reputational levers. it's about comparing the results of hospitals or professionals, and this can push clinicians, managers to improve some aspects just because they saw they are not at the same level of the colleague. And another key incentive can be the community of practice, the networks like this one, because this kind of networks are a way for sharing good and best practices to learn from the others, and this is a very good incentive for push the use, the adoption and the use of this data. I can also speak for hours, but I think it's enough.
Thank you very much. It was very, very interesting.
Okay, thank you.